hour following the webinar, you will receive the evaluation and continuing education request information. This webinar is approved for 1.5 PCD and/or NADAC credits. You can also request a general certificate of attendance. I will go over all of this again at the conclusion of the webinar. And I would like to take some time to introduce our presenters. Sean is the main presenter for the webinar. Sean A. In Tama, Iowa, he earned his BA from Buena Vista University and studied mental health counseling at Drake University. Sean works as a senior behavioral health consultant at the National American Indian and Alaska Native ATTC. We also have Tracy McPherson on. She'll be introducing the SBIRT model to all of you. Tracy is a senior research scientist at NORC at the University of Chicago. Over the past 13 years, Dr. McPherson has led initiatives supported by NIDA, CSAP, NHTSA, NHLBI, SAMHSA, and the CDC. She co-leads the Brief Intervention Group initiative aimed at changing the way employee assistance providers of behavioral health care services assess and intervene for substance abuse by adopting evidence-based screening, brief intervention, and referral to treatment practices. Lena Thompson is a supporting presenter from the American Indian and Alaska Native ATTC. Lena earned her MPH degree from the University of Iowa College of Public Health. She's worked on health campaigns in Iowa and also abroad. Lena works as a research associate at the National American Indian and Alaska Native ATTC. All right, if you're ready, Tracy, I will hand things over to you now.
Thank you, Crystal. All right, thank you everyone, and welcome, and thank you for inviting me to speak with you today. What we're going to do, just to get us started before we have our main speaker sharing with you what they're working on and their experiences, I'm going to give you just some highlights, a little bit about what is screening and brief intervention for those who may be more new to SBIRT or more novice or haven't thought about it in this particular way. This webinar really, the materials that I'm presenting are really produced in partnership with many different folks. As you know, we're supported by SAMHSA, and our partnership is among the National Screening, Brief Intervention and Referral to Treatment, ATTC, as well as ATTCs that Sean and Lena work with, and NORC and the BIG initiative. So just to get us started here, you know, we've thought about substance use in a lot of different ways historically. We've thought of it as a criminal problem, a moral problem, a family problem. We've thought of substance use issues in many different ways, but historically, we really have not thought of substance use or misuse or excessive use of substances as a public health problem. That has really been something that has evolved with our thinking and our understanding of substance use disorders as a medical disease, as the development of substance use concerns in a way that we can potentially intervene early. So this really, what we're talking about here is a real shift in our thinking, and our government agencies and many medical associations have really come to recognize substance use as a public health issue. And so what I want to talk to you a little bit about is about how our current model, how we approach substance use, and this current shift, this paradigm shift of how we are now thinking about substance use, and how we're really developing tools and utilizing tools more from a prevention, early intervention perspective, which is what we draw from the public health arena. So we're learning from public health as we address substance use. The public health system of care routinely screens for all sorts of potential medical problems. Yes, some exist, but they are also screening for risk. cancer risk, diabetes risk, asthma risk, hypertension risk, lots of risks. We now routinely screen for lots of these medical conditions, and we provide preventative services. We do blood pressure measures routinely. We take temperatures. We do a lot of things as a preventative measure for all sorts of medical problems to prevent the onset of acute symptoms. And we want to do this to delay or preclude the development of those chronic conditions. Ironically, we've never really done that with substance use, and that's what you're seeing a shift in and a real movement towards addressing it as a public health issue that we're going to routinely screen for to prevent individuals from developing symptoms and substance use disorders. One way to look at this is sort of the red light, green light approach. We sort of do nothing or we throw everything at a problem. And historically, we've done that. If someone doesn't meet substance use disorder criteria, we say, oh, they don't have a problem. We generally say, oh, drink responsibly. A lot of public campaigns around drink responsibly. We don't really do anything. We don't provide any intervention. We might do a little bit of primary prevention, but we typically do that with young people. We don't do that with adults. And if someone has a substance use disorder, then we look at traditional treatments or suggest abstinence. That's really historically how we've approached it. Another way to visualize this is thinking of that approach along a continuum of how we currently have been addressing substance use. We have abstinence, and then we say, oh, everything is sort of responsible use. And then on the other end of the extreme of the continuum is, then it's a substance use disorder or addiction. And so now what you're seeing with, as we really move to that public health approach, you're really now the definition of how we address this from that perspective is really relying on a framework that we very fondly refer to as screening, brief intervention, and referral to treatment, or SBIRT. Because now we're really delivering early intervention and applying treatment as appropriate, but we're really looking for those who are at risk for developing a substance use disorder, trying to get there early to prevent things in the same way we do with other chronic conditions. So now we're really we're shifting our definition of the problem, and we're now defining substance use or risky substance use and looking at excessive use of substances. And the SBIRT model really recognizes that full continuum, and that full continuum of substance use behavior, of problems associated with substance use, even at a sub-threshold level not meeting diagnostic criteria. And it provides a full continuum of substance use interventions, the right touch at the right level of risk. And so the SBIRT model provides a set of tools. There are tools that we can utilize in employing the SBIRT model to really match the right resources to the area of need. And where the greatest need is, we would have the greatest and more intensive touch. So here's another way of looking at how we are now evolving and currently moving to more accept how we're going to approach substance use issues. So again, we still keep the red light and the green light in there, and there can be no problem, and there could be a substance use disorder. But the interesting thing you'll see here that's new is for the green light, you'll see we have primary prevention and drinking responsibly, but screening and feedback. In an SBIRT model, we do apply screening and feedback even at the lowest levels of risk. And then where you really see the evolution of our thinking is the excessive use. So this is the at-risk, heavy use, at-risk use, binge drinking. We call it lots of different things, excessive, harmful use. And what the SBIRT model helps us do is have a framework for providing interventions, brief interventions, at the right level of risk. And really the goal is to prevent people from moving into high risk, developing a substance use disorder, and also moving those who are in that yellow zone down to lower risk. And so we have brief intervention and we have brief treatment, or multiple brief intervention sessions over time that have shown to be effective in reducing risk and preventing those from moving into having a substance use disorder. Another way to look at this is along the continuum. The SBIRT model continuum looks at substance use this way. So yes, we have abstinence, but we talk about experimental use typically in young people. We have social use, and then now you're seeing more discussion around that binge use, abuse, excessive use, harmful use, at-risk use, and that's where the SBIRT model, I think, is sort of the sweet spot of applying those interventions at those risky levels. And yes, on this continuum, we still have those at the substance who have a substance use disorder, for which we would want more to deliver them to more intensive treatment services. And last but not least, this is another way for you to think about this. So you have drinking behavior along this pyramid. Along the left, you have the low risk or the abstinence. So this is the low risk use, the social use. And then going up the pyramid, in the last slide, it said excessive use, but we also refer to this as hazardous, harmful, or symptomatic use. And at the top of the pyramid is substance use disorder. And so you see 75% of the population, of the general population of healthy adults, are going to score or be at the low risk or no risk range. And for those folks, we generally don't apply an intervention, but they would get a light touch in an SBIRT model to provide screening and perhaps some feedback about how they did score at low risk and what that means for them, congratulatory feedback. The 20% is approximately 20% of the general population of healthy adults would score in this at-risk range, and this is that place where the brief intervention, the brief treatment is very appropriate. And I would just like to point out that that 20% in your setting, if you're in an emergency room, might be higher. It could be 40%. Or if you're working in an EAP, it could be 23 or 25%. So that number does change depending on your setting and population. But it gives you a sense of that's really what I call the sweet spot of screening and brief intervention is there. And then at the top of the pyramid, approximately 5%, in some populations, maybe it's 7 or 8%, might meet criteria, and that's where brief intervention and a referral for additional services would be warranted. And I prefer to say linkage to additional health care services is really appropriate, delivering them to care, not just referring them. So I'm going to stop there, and I'm going to hand it back to Crystal, and I hope that gives folks a sense of where we've been thinking, how we're thinking, and a little bit about SBIRT, and we're going to learn more about how that's being applied in a very specific population. So thank you.
Thank you so much, Tracy. I'm going to hand things over to Sean and Lena now so they can get started with the next portion of our program. And just a reminder, if you do have any questions, you can send them via the chat box or the questions panel.
Hey, Nita. Ready?
Okay, this is Sean Bear. Lena is here with me. We'll be doing the presentation. Welcome, everyone. We're looking a little bit at the overview right now about substance use disorder risk in Native American and Alaska Native populations. Go into some culturally informed practices, benefits and barriers to SBIRT, and then future steps. So then looking at substance use disorders in Native Americans and Alaskan Natives, you need to remember to let your staff know to understand a little bit more about substance use disorders, remembering that alcoholism is considered a long-term issue, just like cancer or diabetes. I know before they used to think that it was more of a personal problem, that maybe they just couldn't control themselves, but remembering that it's long-term, and that just like some of these other disorders or health concerns, that it takes a while, takes a long time, many times a lifetime to help oneself. Remember to let them know that that alcohol or drugs are unsafe, that they play a role in deaths many times that can be prevented, and that it not only affects themselves but also family, community, their employment, and overall wellness. A lot of people may not always understand what it's doing to their family or how they feel about it. Many times, like the children, there could be some kind of sense of shame. With a spouse or loved one, they might be very concerned. So then looking at that is also to look at like low-risk guidelines, high-risk use. With low-risk guidelines, it's really designed to keep risks of developing other illnesses or death low. It doesn't mean there's no risk. High risk is really anything that can lead to further incidents or accidents. Also, you might think of is high-risk use may lead also to addiction. With Native populations, substance use is more frequently associated with suicide. Also working with Native Americans to remember trauma and a concept of historical trauma. One thing to remember is that the use of SBIRT and many different programs and things like that are designed for many people, that there has been very limited studies with Native Americans and Alaskan Natives. So we'll be getting a little bit into culturally informed practices and knowledge, things to familiarize yourself with. So we get into the concept of indigenous knowledge. And it's local knowledge unique to a given culture or society, has its own theories, philosophies, science, and logical validity. It's used as a basis for decision making for all of life's needs. What I really liked how they're talking about delivery of care. And I think it's very important with the use of SBIRT sometimes to use introductions, to utilize soft handoffs, working with the natives, to not just say someone will be here and help you soon, but actually introduce them. So then here, looking at medicine wheel, you'll see that the color there, it's various colors, but the way that I wanted it to be was because many different tribes or beliefs, there are different colors in different areas, but I guess with this, it was my hopes that they would pick the colors that they would like on there themselves. I'm trying to be a little bit more, I guess, politically correct here. But a lot of that has more to do with different parts of oneself, even though they're actually really all together. So then the body, it's remembering to honor yourself and to eat right, get exercise. Honoring one's feelings, or others even, is to pay attention to those. Don't harbor unhealthy feelings. With spirit, many times, I guess, in religion, they think of spirit as one way, but with the natives, spirit has to do with everything. Everything has a spirit. With the mind, to honor one's mind and not to utilize drugs or anything that may interfere with that. So then also when we get into with Native American patients, clients, remembering that their background and what they may have been through, how they may have been treated in the past. They may feel that non-natives might be racist or will discriminate against them. They may feel that they're in poverty or they're violent. So then a lot of these things we're really getting into is different stressors that many different ethnic groups might feel. And it's going to affect how they view you and how they might even hear you. So then looking at different research has been done, the different knowledge that people may read from books or even personal biases. Looking a little bit at cultural sensitivity, cultural competence, cultural humility. I really like the concept of cultural humility. You know, cultural sensitivity might give you a little bit of understanding of principles and morals, different practices that are done in the culture. Cultural competence is, you know, it's kind of like they say it qualifies one to speak of a culture. But cultural humility is at a higher level when they're actually staying with the people for a while. You know, they're learning all these different ways. They're understanding them things from their own background as well. And it helps them to be able to be a little bit more subjective, more when one can understand certain parts of these different cultures, they're a little bit less likely to say something or think something sometimes even that might be construed as disrespectful to another culture. Looking at the concept of traditional medicine, the WHO, they describe it as a sum total of health, knowledge, skills, and practices based on theories, beliefs, and experiences indigenous to different cultures, used in the maintenance of health, of physical and mental health. Now they also have ones with alternative medicine, as homeopathic medicine, complementary medicine, but it's a broad set of health practices not part of the country's own tradition and not integrated into the dominant healthcare system. Well, one thing with natives you need to understand is that we're looking at this. Now, the way that natives are going to view traditional medicine is a more comprehensive of all of life, a balance, symbiotic relationship and respect, but also recognizing interacting reciprocally in real relationships on a physical and spiritual level. The way that we would view the modern, or how the medical field says that traditional medicine, we would see that as maybe a Western approach, a new, adapted, adulterated, combined, or even sometimes New Age. So then looking at that, the way that natives see tradition is old. It's something from a way back when our ancestors had even more power than they do today. They were able to use herbs or healing, natural ways of doing things, but it comprises all of life. Today, the medical field kind of uses in their way more modern ways, pills, operation procedures. It kind of must be understood by others, because in order to speak to them about traditions or medicines, the views might be different. The way that medicines are seen many times with natives is using natural ways. There's also a different kind of beliefs, is that with the medical field, those are medications that they use. With natives, it's medicine. And if you look at different things, I know a lot of people might kind of not always understand, like, well, the herbs, maybe they're dangerous. You know, we always hear these things from doctors, clinicians, whatever it might be. But you need to remember also that with medicine, there's approximately 75% of all medications today originated from indigenous knowledge. I think down south in South America, there's also some court things going on, and what they have termed biopiracy is when they're actually taking this knowledge of herbs and such from the people without giving them the acknowledgement that they deserve for these. Lena's going to talk about trauma-informed care.
Hi, everyone. So trauma-informed care, let's see here. Trauma dynamics can be repeated both knowingly or unknowingly in a therapeutic setting. An example of that is a disbelief or a lack of interest in trauma history. Do you want to talk about that just a little bit? Disbelief or lack of interest in trauma history?
Well, I know with natives, the way that we always hear is that, to let go of that, don't harbor those feelings, forget about it, it's the past or anything, but you need to also recognize and remember that with trauma, can be passed down from parent to child, but over many generations, it's become to affect them a little more so. So when somebody has a disbelief or lack of interest in trauma history, I mean, it's a little more like in Europe saying that what happened with the Holocaust is not important. It's the same kind of thing with the natives.
Thanks, Sean. So trauma-informed care, really looking at natives from a perspective that they, as an entire culture, have been extremely traumatized is so important to dealing with the individual person. So using trauma-informed care with natives prevents re-traumatization and ensures greater support for them and encourages a healthy lifestyle and atmosphere for them. Some examples of empowerment would be providing a space for your staff members to become positive role models, focusing on strengths. That's one thing that I've learned a lot from working at our center is focusing on strengths. What can we do? What can we do well? And not focusing on what we can't do and what we're not able to do at the time. So looking at experience-based practices, we have experience-based practices, and they are also as important as evidence-based practices. So a lot of times my linear thinking brain wants to think about evidence-based practices. How many scientists have proven that XYZ works with a population, when really, if you look at an experience-based practice, what has worked in that community and what has worked for these small groups of populations, that is important too, and that holds a lot of value for Native populations, especially because there aren't as many evidence-based practices with Native populations as we would like to have. So from a public health standpoint, from a community-based participatory research standpoint, we really do suggest also taking a look at experience-based practices through talking with people who are Native, through reading from them, but it doesn't always have to come exactly from literature in order to still be an important and well-known way of doing something.
Okay, looking at health, you need to look at the whole person. It's much like the medicine wheel. This one here breaks it up into further parts, looking at biology, social, economic, education, gender, human rights, environment. This is much like how, I guess, natives might see things like a person in a way, but also looking at the medicine wheel, it might further go into, you know, spirituality, different cultural things, practices, medications, medicine, ceremonies, and such. From that point is to remember culturally informed practices, remembering to have respect for cultural-based knowledge, facilitate the uptake of science-based knowledge, but understand the essence of an assessment and treatment approach. Looking at many different programs that have been made, they've been followed, and it's been, you know, scientifically proven to be evidence-based. A lot of these programs that have actually worked with natives are not those that they took into a native community and said, here, do it this way. The programs that have always been successful with the natives are those that went to this tribe or culture and to utilize what they already have in place and then add some of this evidence-based practices along the way. Culturally adapt appropriate knowledge, also with using some of the culture as treatment. Sometimes it could be looking for others within the community or their own background to look for medicine peoples, look for healers, spiritual, our elders within that culture. At the assessment, I guess before it even gets to that is to the screening option, you know. So then when you screen a patient or client, to remember that through the screening process that not all people actually go to an assessment. It's kind of screening whether they have a problem that warrants further assessment or evaluation. During this time, you might look at getting to know the client, remembering that through when you're looking at a treatment process that it's the beginning of a relationship, and many times building rapport starts there. With any kind of planning, whether they go to treatment or any kind of care for themselves, maybe educating them, working with them right there, even before you go to treatment or anything like that, to collaborate with them on that, and or the family, making sure that you follow up with them, helping them to understand chronic disease, and remembering the ROSC model. The ROSC model, the recovery-oriented systems of care, work very well with Native communities because it follows along with how the community works. So this may tend to go a little bit further into a cultural evaluation to see where this client is within that culture. If you looked at here, not all natives are going to be traditional. Not all natives are going to be bicultural or assimilated. The assimilated way and traditional ways. The assimilated peoples, they might not want anything to do with their native background or their culture. So that's something to keep in mind, that with Native Americans, they're not always going to be in one basket. Their worldviews are going to be different. The way they see themselves is going to be different.
So I'm going to talk a little bit about some of the different ways that Native Americans might think about the world or process the world. So linear thinking is a little more common for those of us maybe who would relate more to the dominant culture. It's a thought process that follows step by step. You go in order. There's a starting and an end point. If A equals B, then B equals C, then A equals C. You know, when I'm problem solving, a lot of times I'll take something from beginning and I'll work through it until the end. Sometimes people who are linear thinking can be very time-oriented. If you ask me what I did today, for example, you know, I might start at the beginning of my day and say, you know, I woke up and then I did these things, and I would go in kind of a pattern, you know, an order. Some Native Americans might identify more as circular or global thinkers. The answer in a global or circular thinking process is where the answer is stated within the argument. It assumes that what you're aspiring to prove is true. The conclusion is a single assumption. There's a certain there could be many starting points, and the process kind of jumps around. So perhaps if you ask Sean what he did today, he might start with the most important thing he did today, and then maybe he'll tell you about the other things. It might not go in the pattern of this happened, then this happened, then this happened, then this happened. And that's important to remember when working with somebody, because we might expect to hear it in a certain way, and we might be thinking, okay, so Sean did this, 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 and this, when really he, you know, maybe he did this most important thing first, or he did this most important thing in the middle of the day and then did other things around the rest of his day. Did you want to say something, Sean? How about you say, yeah, go.
It's kind of neat though when you think about it. I remember I was presenting in Arizona New Mexico last week, and somebody, I guess even the week before that or the other week before that, I was in Minnesota, and I was presenting with a non-native. And at first we did our introductions, and of course I let them go first. Right away they started talking about their education, where they work, what they've learned in college or school or whatever they might have done. So then when I got in there, I kind of like told a story about myself, you know, a little bit different. But they realized, the other presenter realized the differences of how we introduced ourselves. They were very different. I gave more of a personal ideal, I guess I could say, of how I might like or want people to see me. But the way that they done it had more to do with education or accomplishments or different things like that. So sometimes those are going to be a little bit different as well. When they come to the bicultural way of life, I guess sometimes they can be more challenged because they're expected to live in two different worlds, especially if they live on or near a reservation or settlement, that when they go amongst their people, they have to fit in there, but they may also in some ways be stigmatized for dealing with a non-native culture. So then in a non-native culture, they may be kind of stigmatized by being native. So remembering that either traditional, bicultural, assimilated, it's going to affect each one a little bit differently. So then in eye contact, a lot of natives may not look at you straight in the eye. During school or education or different programs, even in a group setting, they might not be looking at you at all. They might be looking down. They could be drawing or whatever, but chances are they are listening to what's being said. So a lot of times it's like, I remember even when I was a child, it's like I wasn't looking at the teacher, but I would get in trouble for not looking. So remembering that lack of eye contact, that doesn't always mean that they're not listening. There are different, even other beliefs where some natives will not trust you if you don't look them in the eye at least once.
And we're also going to go fairly quickly through some of these Venn diagrams and just showing different parts of Native culture that might be a little bit different from dominant culture. I want you to remember that although we show it all these different ways, and we say that handshakes might be non-aggressive, for example. I mean, different people are going to have different ways that they interact with people, so this isn't, these are blanket statements that might not apply to absolutely every person. But generally, a person who is a traditional Native American would have a less aggressive handshake. I've learned before that in some Native cultures, the person who is younger, or if you're trying to show respect to an elder, for example, your hand pressure would be just slightly less than the elder. So you kind of touch and you start shaking, and then you kind of feel out how the other person is gripping. And if you are the younger person, you would go a little bit less. In the more assimilated culture, for example, an aggressive, strong handshake shows that somebody is confident and somebody is willing to engage with you in a conversation. So an assimilated culture, aggressive handshakes might be more, might be seen as a better thing. Bicultural people will kind of walk in both of those places. So in a traditional setting, they might have less aggressive handshake, and in a non-traditional setting, they might have a more aggressive handshake. Communication style, the traditional person might be very verbal within their own culture, maybe within their own language, but outside of their own culture, they might speak as much. They might not communicate quite as often. Their body language might be a little more reserved as well. Somebody who's assimilated could be highly verbal or more verbal, want to talk and interact and discuss different things that happened. And again, somebody who's bicultural would fall into both of those spaces. Response time as well, so important when working with somebody who's Native, specifically traditional Native, to give them a little bit more time for a response. Sometimes it's hard when we ask a question and somebody doesn't answer right away to just sit there and wait, but that is possibly helpful for somebody who's traditional. They might need more time. They might be processing bilingually. Oh yeah, and you know, I mean, you don't want to think that they're not smart or that they don't know. They just might be processing a little bit longer. Emotions are not traditionally exhibited outwardly. Somebody who's traditional would be a little more reserved, whereas the assimilated population might be more outgoing, and again, bicultural might be reserved in a more traditional setting, less reserved in an assimilated setting. When helping somebody who is crying in a traditional setting, you might want to just wait until the tears have stopped and let that person go through that phase of crying. In a more assimilated culture, you might console that person right away. Anger tends to be more suppressed and subdued in a traditional population, whereas in an assimilated population, you would express that anger. In a more assimilated population, we might be open with showing affection, we might be private. It just kind of depends on that individual and how they have grown up and how they like to show affection. but in a traditional setting, it is more common to be private and modest with showing of affection. I know that joking and teasing with somebody can be a way of showing affection. So if somebody who's Native and traditional is comfortable with joking with you, that might mean that that person likes your company and is showing you affection. Oh, look at that. So within the culture, a traditional group might be very humorous. They might have some inside jokes or some darker humor and comedy. And then outside of the culture, it tends to be reserved. Assimilated tends to be like non-natives. Some people like humor and teasing and some people don't. And then bicultural, people kind of jump amongst or between those different ways. It's important to remember that somebody who's traditional does not place much value on possessions. They might not have a nice car, they might not be wearing the most updated clothing, but that doesn't mean that that person isn't doing well or isn't doing okay. To them, they might not always have a bank account that has a whole lot of savings in it, just because to them they use that money and they give that money to those around them. So it's more common to not accumulate all the personal possessions, but to give away those possessions and share them with other members of the family and of the group. Assimilated might be a little more similar to the dominant culture where things are viewed as status symbols. And bicultural might kind of jump between the two, which would be pretty challenging because if you have a lot of things and you're in a more traditional group, you might not fit in as well, and vice versa. In a traditional Native American group, they are more event-oriented. I had somebody tell a story 2 weeks ago on when he was about to start something with a group of Native people, and everyone was there 15 minutes before the event was supposed to start. So he went ahead and started, and some of the people who were more assimilated were so confused and so shocked that he would start 15 minutes early even though everyone was there. So sometimes we think of Native Americans as we hear Indian time or something, which a lot of people think to being late, but it just means when it's time to start, they know it's time to start. So it could be early, it could be late. And assimilated, we're a lot more focused on the clock in the traditional or in the dominant culture, so assimilated is closer to that.
Okay, another way of thinking about this is there's some other ways that's not always spoken about is those who are more spiritual. Now you might get into the healing practices, that more deeper into spiritual ways to understand the different aspects of things within life. Some may even communicate with the spirits. I guess in a way you can look at those with the culture as those who are a student of spirituality within, I guess many might consider it like New Age. There's also another way that is not always spoken about is those who practice some medicine way, and those are ones who is actually living every day and utilizing all these different spiritual concepts and beliefs, everything. And these will likely communicate with the spirit world sometimes all day long because they respect everything about creation and that knowledge and knowing that every tree has a spirit, every stone has a spirit, there's a spirit within the air, the trees, you know, the water, everything that's here. So then these are much like the medicine people within our culture. Looking at a lot of the orientations between the traditional, bicultural, and assimilated is the worldviews might be different. Their self-esteem might be different in the way that they see life and themselves. Looking at this here, you'll see how many of the mainstream society of America, a Native might go through and they could be accepted or respected. They might feel rejected or oppressed. They might feel discriminated against. But then looking at the world, it's kind of like a filtration process or system where some are viewed as, maybe they're military or they're employed, they're educated. I mean, there's always these different facets of whether somebody's more educated or has a certain job or different certain religious beliefs or whatever it might be. But with the Native peoples, it's like we're kind of forced to live in the two different worlds that that we see every day. So in a way, it can bring some stress. Talking a little bit about building rapport is, it's kind of neat, but you need to look at everything about it. The way that you communicate, remembering to show respect, to have empathy, compassion, trust, show a genuine cultural interest. So if you're utilizing a lot of these different things when you work with Native Americans, have a better chance of helping them and yourself to build that rapport with them. Here is sample identity assessment questions. Is how do you identify yourself, either traditional, bicultural, assimilated? Do you have other ways that you may identify yourself? Are you okay with who you are or who you feel you are? Do you think your friends would identify you as how you say? Have you ever experienced any feelings of inferiority related to your ethnic identity? If so, how has that affected you? Have you ever experienced prejudice from tribal members or non-tribal members? That's important too, because if somebody is considered assimilated or bicultural within their community, are the traditional people going to treat them differently? Or if they're enrolled or not enrolled, how are they considered? So looking a little bit at historical and generational trauma, remembering that long ago, it's what they say is it was about 10 million Native Americans here, and then by the time of the 1900s, it was down to 250,000. So a lot of natives, they can, this could affect them. Some of them might think about it daily. Some might think about it monthly, weekly, or occasionally. So some might be more angry than others. Here's one, again, it's like after military defeat, American Indians experienced one of the most systematic and successful programs of ethnic cleansing in the world. They, in a way, became forced to be dependent upon the U.S. government for food, shelter, health care. With the food, they were given commodities. With their shelter, of course, it had changed. In some ways, we're a circular people. We look at the circles in the world from life to, in a sense, rebirth. That whatever happens will come back. Hardly anything within nature is square. Pretty much everything is circular. One thing I've always kind of said was, we're a people that believe in a circle. We lived in a circular world, lived our life in a circle, but we were forced to live in a square one. All life was under control of a foreign government. Leaving the reservations often became illegal. You couldn't hunt off the reservation, and our traditional ceremonial practices became illegal. It wasn't until 1978 that the religious American Indian Freedom Religion Act was passed, and it again allowed for natives to practice those ways. A lot of the symptoms of historical trauma could be PTSD. They might have some anger or rage around this. They could be depressed. They might have anxiety. They could turn to alcohol or drugs. They might be in denial. They could have nightmares, memory loss. That's something that's very common with natives is beliefs of certain information can be passed to them through dreams. So then daily reminders of this could be just living on a reservation itself. Family system. Today we see more violence, domestic, physical, sexual violences when these things didn't happen before. These were something that was considered very, very wrong, and many of the tribes had their own ways of dealing with it if it ever happened even once. So many times after that it would never happen again. Military experiences many times are different, where because you're native you're considered to have these supernatural powers and all these gifts very fast, really strong senses or whatever, so you're automatically might be placed in a more dangerous positions, you know, as being a point man or being in the scouts or something like that. You may have loss of parents or relatives or friends. There are youth taken away from families and put in adoption or foster care. And I think it was in the 80s that they considered and termed the use of split feather syndrome, because of there were many of these youth, even when they were a little baby, and they wouldn't remember their time with their people on the reservation, that many of these were diagnosed with mental health disorders. So they wanted to look at that and see what was going on, and a lot of this came from their belief systems that they already had, or abilities to be able to sense things, you know, spiritual things that others couldn't. So the families took them to an assessment. They were diagnosed with mental health disorder, but they found out that many of the natives had an innate ability to be able to sense these things anyway. So that's when they really started to try to get native children with native families. Looking a little bit at SBIRT, remembering that it's very important for the whole team to understand the importance of utilizing the process of SBIRT, the use of MI, and unconditional positive regard, using cultural sensitivity, competence, and humility, remembering that it takes a team effort to do this. So from the top to the bottom, everybody needs to understand this and have this as part of the way they deal with natives and others. It is used for, again, as like I said before, early intervention for people who are at risk or those who may be developing substance use disorders. In the screening process, like I said, remember, this is designed to be a quick assessment of the severity and the use of a patient or client. It doesn't mean there's going to be a referral to treatment. Remembering to let them understand that. Screening doesn't mean treatment. It's just to assess whether someone needs further assessment. And some of this might be done through brief intervention, utilizing education to raise awareness, what might be going on, let them know the dangers of further use. Uses concepts and practice of motivational interviewing. So then it's like you might wonder, it's like, why don't people change? Well, a lot of times either they don't see or don't know the impact, or don't know, or maybe they don't care. So remembering some of these beliefs tend to go further on. Well, maybe if I can make people see or know or teach people how to change, or maybe sometimes if people might think if they can make them feel bad or afraid enough, they will change. Wow, what happened there? Okay, so then remembering that through the change process, that the nature of change is that people naturally feel two different ways about something. Part of me wants to change. The other part of me does not want to change. And remembering that people are usually more convinced by reasons they discover themselves than reasons presented by those found by others. So remembering that to give your patients or clients a choice, and sometimes if they feel they have a choice, then they're more likely to comply. Looking at the change process by Prochaska and Di Clemente, you look at, you know, pre-contemplation, contemplation, preparation, action, maintenance, or relapse. Well, remembering that pre-contemplation, they may have no idea what's going on. They may have no idea that there is a problem. Contemplation is, they might begin to think, well, maybe I do need to change something. Preparation is maybe they've gathered up all this information and said, well, then I need to do something about this. And that's normally when people may go for help and get an assessment. Remembering that with maintenance, it's after that. So once a person's in recovery, they're always going to be maintaining things, whether they're going to stay away from certain places so that they don't have these triggers and urges. If they're going to stay away from certain people, sometimes it takes time. It's like remembering that change can be very difficult for people. So then there's different ways of looking at change. But, you know, even, I don't know, there's a little thing I used to like to do with clients and some of the people about change, and it really lets people know that any change is difficult. But remember, even if they have a lapse or a relapse or something like that, remembering not to further harm them in a way of saying, what did you do? Why did you do that? You know, many times when I look at that within treatment was, if they felt bad about it, to me, many times that was good enough. So I'd ask, what did you learn? To me, the danger sign is they see nothing wrong with what happened. So then, but remembering that relapse is part of the recovery process. It doesn't have to be, but it's part of it just in case. Usually, remember looking at this as recovery treatment process usually takes 1 to 2 years, so it's not going to happen overnight. Looking at the stages of change, I think we've covered this a bit. So ways to avoid communication traps is, don't rely on just a question-answer trap. It's just asking a question and just waiting for them to answer. Don't be labeling people in certain ways. Remember, sure, not to prematurely focus on certain things that may or may not be the main concern. Don't try to pretend or something that you're an expert about all these different things that will put clients off. Don't, sometimes even confronting them, denial with denial can be a problem. Before they used to say if you're in denial then you have a problem, but that's not always the case. Remember not to blame. And looking at referral to treatment is make sure that you get a consent from your client, making sure that your client is agreeing to this. Utilization of, say, soft handoffs. Maybe sometimes you might need to introduce the patient or client to the person who's going to meet them next, make it a little bit more personal. Having them be with you when you make an appointment or making a call. When a lot of times what we learned was when patients or clients didn't go to an appointment or go to treatment, as they said, it was because they never really got a commitment from the client. Maybe they didn't get a transportation. Maybe they just forgot. So remembering to follow up with them. Maybe sometimes they might just need a call reminder. Making sure the scheduled time is considered that will work with them.
I think another thing that we can sometimes get caught up on is running on program-driven plans. So we'll say, this is how our program is written, this is what we do, this is what we've always done, and this is how we're going to continue to do it. Program-driven plan might often include only those services that are immediately available in that agency, does not include referrals to community services, are not necessarily culturally responsive. So we might have our program-driven community or a program-driven plan and not really think about some of the other outside resources and not really think about making our plans individual-driven. So think about referring to some of the community services. Are there parenting classes? Are there cooking classes? Are there exercise classes that you can take a look at and see if maybe those would be helpful for a client? Are there other things, other services that maybe aren't immediately available or that you haven't worked with before that might be beneficial? And can you reach out to them? Can you give them a call? Can you connect with them? Really focus on what will help this individual and maybe take a step back from how things have always been done, because there are lots of other ways we could do things. Sometimes our service models don't always match exactly what a person needs. Focusing on motivational interviewing like Sean talked about and really focusing on the person might help us match the needs that we see with other organizations and other groups and other models that can help somebody. And really think about creating an individualized plan. I'm sure all of you are awesome at this, and I really trust that, but just take a step back and think about the individual and what they need. As just kind of a recap, you know, we've talked, well, Dr. McPherson gave a really great overview of SBIRT and how it works, and I hope what we were able to add to this conversation was how Native populations might need you to adjust your practices, the way that you screen to them, by thinking about the ways that their culture is different, by thinking about the background of historical trauma, and by considering that plans might, or that programs might work in one specific way but might need to be adjusted for a Native American population or a Native American person. Go ahead. You can finish it. You want me to go? Okay. Well, so just following that, do your agency's goals match what you are doing? And furthermore, do your agency's goals match what the person you're working with is doing and needs you to be doing? So just think about, you know, maybe what your strategic plan looks like, maybe how some of those things can be adjusted for Native populations, and just how you're approaching those people in general, because there's a lot of history and a lot of cultural differences that aren't always followed and respected when working with Native populations. So that brings us to the end of what we had prepared for you today. If you have any questions, go ahead and I think type them in the box. Is that correct? I'm not really sure what's... Are you there, Crystal?
Sorry about that. I'm here. We have had some questions that have come in over the course of the hour and a half. The first one is, what are some important specific aspects that should be included in a screening or brief intervention? And the example is, maybe, is it possible to use the medicine wheel to identify risk factors?
I believe it is possible. I know that in some ways, looking at an assessment evaluation with the medicine wheel, you're able to look at the physical self and how they're doing, looking at emotional self and how they're doing, the mind and more of their spirit. Because a lot of times it's like what usually happens with Native Americans is spirituality is the first thing to go. And a lot of that can be due to respect of their belief systems, because in a ceremony or something like that, they're not allowed to utilize their alcohol or any drugs for many times so many days, or sometimes very, very long time.
Great, thank you. And the second question is, could you provide some resources and references that share approved ways for talking and engaging with Native Americans in an effort to not disrespect their culture? And if there are things that you want to link to or anything like that, we can certainly round up those links and send them out after the webinar. But if there's anything you'd want to share now as well, that would be wonderful.
One thing you would need to consider is not all tribes are going to be the same. So then different tribes are going to have different beliefs, different practices in the way they do things. So that's going to be a little bit more specific to each tribe usually, and sometimes even down to different clan systems.
Okay, and then we've had a question in the study that was referenced. What was the percent of females versus males who were using alcohol and other drugs?
Was that something we shared? Percent of females? I mean, I have to look that up and get back to them.
Okay.
I don't know.
I'm pretty sure it's very common with looking at that. It's just like how.
And at this time, I'm going to take a moment to go over our evaluation and continuing education instructions. So today's webinar is approved for 1.5 free PACADC continuing education credits, as well as 1.5 free NADAC continuing education hours. You'll also be able to download a free certificate of attendance following the webinar at your MyIRETA profile, and the link is there below and will also be in the email that we send out following the webinar. Additionally, in the emails that we send out following the webinar, there will be a PDF version of the presenter's presentation, as well as a link to the evaluation. Our grant evaluators are required and pleased to collect feedback from all event participants. Completion of this evaluation is critical to maintain our funding and continue to provide quality education and materials. Your participation is appreciated, and the evaluation should take no more than 2 minutes of your time. And also in the email will be the link to a request form for the Certificate of Attendance or NADAC and PCB CDUs. Should you decide to skip the evaluation and proceed directly to the CEU request, you'll need to leave all the answers blank on the evaluation. Again, we want to thank you for your participation today, and if you have any questions regarding the presentation or how to request your CEUs, feel free to get in touch with us at info@ireta.org.